Welcome to the Alliance for Home Health Quality and Innovations webinar on the bundling and coordinating post-acute care or BACPAC analysis. My name is Teresa Lee, and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance was founded in 2008 and is a 501c3 foundation dedicated to the mission of sponsoring and fostering research and education on the value home health care has to offer to patients and the entire U.S. healthcare system. The BACPAC analysis that we're releasing today builds upon previous analyses sponsored by the Alliance and performed and completed by Dobson, DeVonzo, and Associates in 2012 in what was called the Clinically Appropriate and Cost-Effective Placement, or CASEP, project. The CASEP project analyzed Medicare claims data in order to identify opportunities for improving quality and efficiency of care and reducing Medicare spending. The project was developed to inform the public and policymakers on how to make post-acute care more efficient, how to improve care overall, and prolong the sustainability of the Medicare program for future generations of America's seniors. One key finding of the researchers in CASEP was that if post-discharge patients were served in more clinically appropriate and cost-effective settings and care delivery were restructured, the Medicare program could save as much as $100 billion over 10 years. Following the CASEP project's completion, and given the growing interest in Medicare reforms that involve bundled payments for post-acute care, the Alliance asked the following follow-up question. If post-acute care only payment bundles were used in Medicare to achieve clinically appropriate and cost-effective placement and to improve care delivery, what are the issues and considerations that would need to be considered? The Alliance sponsored this BACPAC analysis that we are releasing today in order to answer that question. The BACPAC analysis that you are about to hear about presents potential structures and components for consideration in the development of post-acute care only payment bundles, while also modeling the financial impact of those payment bundles. To dive deeper into the BACPAC analysis, the researchers who conducted this project, Dr. Al Dobson and Audrey L. Gamil with Dobson, DeVonzo, and Associates, will present the bundling and coordinating post-acute care toolkit. Just a few housekeeping notes before I introduce them. First, our guests will speak for approximately 30 minutes and will leave the last 20 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so please don't be surprised if you are not able to flip ahead. Second, your lines will be on mute. You can submit questions to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. You can send a question to the speaker to be answered in the Q&A period by sending a question to me, Teresa Lee. Finally, please be aware that we are recording this webinar, including the Q&A period, so that we can provide a playback on our website for those who were not able to participate live today. Last but not least, please note that you will find on our website the full report containing the BACPAC toolkit and analysis, as well as the press release and summary materials immediately following this presentation. Without further ado, I'd like to introduce our two speakers today. Al Dobson is the primary researcher on this project, and he's greatly respected by the healthcare community as a whole. He is a health economist and president of Dobson DeVonzo, and before he co-founded the firm, he directed the Lewin Group Healthcare Finance Group as senior vice president. He has served as director of the Office of Research at CMS, and he testified before the U.S. Congress, MedPAC, and various state, federal, and presidential commissions on healthcare finance, provider payment, and health policy issues. Audrey L. Gamil, his associate from Dobson DeVonzo, who's a senior manager there, brings 9 years of experience in health policy analysis. Prior to joining Dobson DeVonzo, Ms. L. Gamil worked at the Lewin Group, where she conducted numerous analyses of various aspects of Medicare provider payment. She has experience in designing and fielding surveys, and she managed a large survey for the General Accountability Office on Ambulatory Surgery Centers, for which she received a commendation from the agency. I'm very pleased to introduce them both, and look forward to their presentation. Alan, Audrey?
Thank you, Teresa. Thank you, Teresa. This is Al Dobson, and I'll guide us through, and Audrey and I will answer questions together.
As Teresa said, findings from the clinically appropriate and cost-effective placement project indicated that Medicare savings could be achieved by healthcare delivery and payment reform, and BACPAC was all about figuring how that might be set in place from the perspective of post-acute care. The second dot point on page 2, a post-acute care bundle triggered by a hospital discharge and a home health, skilled nursing facility, or inpatient rehabilitation facility admission could be designed to incentivize clinically appropriate and cost-effective care and generate substantial savings. So what BACPAC is about is designing a system around the last half of a bundle, so to speak, after somebody's discharged from a hospital and then is admitted to a home health SNF or IRF. That's when our BACPAC bundle starts. Am I coming through?
Keep going.
Okay, great. Page 2, third dot point, focusing a bundle on post-acute care, excluding the index hospitalization, would allow for the development and implementation of a bundle and coordinated care networks for mitigating provider risk. The idea is to work on the transitions of patients as they leave the hospital, move through the post-acute care sector and the community, that is, for this first, say, 60 days after somebody is discharged from a hospital. Moving to page 3, study highlights, continued. A convener, either third party or provider, would be essential to allocate. We're getting static. Somebody's working with a keyboard. A convener, either third party or provider, is essential to allocate patients to the most cost-effective. There has to be a care coordinated function, which would be provided by what we're called a convener, which is essentially an organization that selects which post-acute care setting a person would initially go to, a patient would initially go to, and then works with readmissions and continuity of care as the patient moves through the healthcare system after the discharge from the SNF, the home health, or the IRF. Now, convener catchment areas, another finding is that size matters. The larger the catchment area, or the larger the area the convener operates over, the more actuarially stable the process would be. Nothing new there. Large HMOs are more actually stable than long HMOs, and self-funded plans actually until only recently were quite large in nature to get enough patients involved and enrollees to make an organization actuarially stable. So the larger the catchment area, the more stable our system of BACPAC would be. Then we decided finally under study highlights on page 3, third dot point, a series of blends and transitions as well as an outlier policy would be required to mitigate provider risk and ensure quality of care to patients. The idea there being that as we try something new, if this were to become payment policy for the Medicare program, we'd want to protect providers. In a way to do that is to blend old payment with news, to have transitions as you transition slowly into the new payment system, the new payment incentives, and finally to have an outlier policy for those providers that had cases that were more expensive than typically. Outlier policy would in effect be an insurance policy for those providers that had high-cost patients. On page 4, post-acute care bundling context, first dot point. Bundled payments for post-acute care services are a logical first step in considering care and payment redesign. Medicare is currently working very hard to consider the next step after its 30 years of prospective payment systems. They have in place Medicare Advantage, as we know, but Medicare Advantage has certain limitations and has most had 25% of the Medicare population. So what we're talking about today is extending a bundled payment system through the fee-for-service sector, whereby bundled payments would represent about half of fee-for-service payments, and the BACPAC would represent about half of the half or 1/4. So from Medicare's point of view, the BACPAC system would represent approximately 25% of current Medicare fee-for-service expenditures, which is a pretty big deal from the point of view of the Medicare program. Second dot point, the goal of bundling is to increase the efficiency of care across settings and encourage care coordination as not currently provided under siloed prospective payment systems in fee-for-service Medicare. Authors such as Mary Naylor, Eric Coleman, the Project Red, Ed Wagner, the Veterans Administration, and Geisinger, which is quite famous for patient reengineering, have argued for the past decade or so that we need to spend a lot more time on care coordination and care transitions, how people move from one setting to another. And what a bundle does is provide payment across the bundle such that there's one payment for a bundle, and the convener in this case would be responsible for people moving through the bundle, reducing readmissions, increasing the downside of transitions where patients are highly vulnerable, and providing for care coordination as, again, people move across one setting to another in the post-acute care setting. The success of bundles and constraining cost growth relies on the delivery of care in the most clinically appropriate and cost-effective and stable manner. Clinically appropriate means that under BACPAC, we would never want to have patients go to a setting that wasn't appropriate for them, but cost-effective in the sense that if there's an even clinical argument for going to, say, home health as opposed to a SNF or an IRF, or on the outside an LTAC, you would go to the most cost-effective and clinical appropriate setting, which in some instances would be home health and others it would be the SNF or the IRF. CMS developed a bundled payment for care improvement initiative called BIPSI, and that investigates and tests how post-acute care payment bundles could be structured, implemented, and paid for. Currently, BIPSI has 4 models, 2 of which are relevant to today's discussion. Model 2 bundles the hospital care and the post-acute care together, and Model 3 only bundles the post-acute care. Our BACPAC is essentially BIPSI Model 3, of which there are some being explored and investigated as we speak in the country today. Due to financial risk to providers, bundle payments must be carefully crafted and implemented with safeguards both for patients and providers. And Medicare is all about these days having quality measures and quality considerations for each of their existing payment systems, and certainly payment systems of the future would call for care with payment and quality measures that would make sure that the payment system is working. Page 5. Page 5 shows, as Teresa said in our prior study, we tried to understand how many dollars might be saved through a bundled payment system. To start with some basic facts, we know that both from our study and from the MedPAC bundled chapter in its March report, that approximately 50% of fee-for-service expenditures relate to bundles, 60-day bundles, including the hospital stay and the following post-acute and ambulatory setting. If we work on those, that 50%, we argued on the post-acute care side only, not counting the hospital stay, but in counting readmissions and physician care, we could save about $35 million, essentially by putting people in the appropriate setting, the most cost-effective setting, appropriate clinically, cost-effective meaning the least expensive. Since home care is typically a least cost setting, if it's clinically appropriate and there's care at home and there would be a caregiver at home, one would guess that a lot of the substitution would be from higher cost settings to home health. That would certainly be a possibility. Again, that would have to be clinically appropriate. Then we ask a different question. If you move on page 5 to the middle bar in the chart, we said, if we wanted to save $70 billion over 10 years from 2014 to 2023, what would the reduction have to be in current expenditures for post-acute care after the hospital admission over a 60-day stay? And the answer is about 5.3% reduction would be necessary to achieve $70 billion over 3. Similarly, we ask a question, what would have to happen in terms of substitution, re-engineering, and a more appropriate transitional care with reduction in readmissions? It would be a 7.5% reduction in post-acute care, readmissions, and physician care. So 7.5% reduction in the post-acute care aspects of the payment bundles, which represent overall about 50% of Medicare fee-for-service again, would net about $100 billion in savings. That would be a sizable number even in today's scoring systems, $100 billion. And we've had people tell us on the one hand 7.5% is too much. On the other hand, gee, that doesn't seem much given the growth of post-acute care in the past decade or so, past several decades. So maybe 7.5% is a reasonable, it would be a fairly sizable target, but perhaps not necessarily unreasonable. Under BIPSI, I believe Medicare is asking for 2% savings, so 7.5% under the current Medicare BIPSI program would be a bit of a reach. So that said, then, we decided and built analytic models that showed that between 35 and 100 billion might be possible for savings under post-acute care reform. Definitely could save savings. The nice thing about this from a scorage point of view is if the Congress said a BACPAC would be enacted and it would save 2.6% of post-acute care, that would be scored at 35 billion because that's what, in effect, the Congress would do. Now, from the point of view of Medicaid, now Medicaid, not Medicare, when Medicaid is implementing Medicaid managed care, typically they take off 8 percentage points, and they, in effect, say, we'll provide the opportunity for managed care to take over Medicaid programs in state X, Y, or Z, and in so doing, there'll be an 8% discount up front, and that will be the score, the savings. And the governor sent out notes and say, we've just saved our state budget 8% by hiring managed care. In this particular situation, the Congress might say, we'll save so many percentage points by enacting a BACPAC-type bundling system, and that would be built right into the amount of money that would flow into the system. On page 6, parameters of PAC bundles. PAC payment bundles could be designed to either include or exclude the index hospital stay. As I said several times now, in BACPAC, the index hospital stay would not be part of the payment system. Obviously, it would be part of the care. There would have to be coordination with the index hospital stay. But from a formal point of view, the payment bundle would be all the care for, say, 60 days after the patient leaves the index hospital stay. So a bundle that includes an index hospital care requires an MSDRG plus the post-acute care management process. That hasn't been developed and it hasn't been tested, although, as I said, BIPSI is, that is the Medicare payment system for bundles, is beginning to test a system that has both the hospital in it, Model 2, and a BACPAC-like, which would be the BIPSI Model 3. Currently, we know that hospitals lack the infrastructure and experience to manage post-acute care, and an advantage of a PAC-specific bundle, excluding the index hospitalization, would be that it would be managed by post-acute care providers and third-party conveners, and it would allow a very specific focus on bundling to function with reduced risk because you wouldn't have the hospital and the post-acute care all in one big bundle, and it would allow us to very sharply focus on post-acute care, how to make it better, and how to have the care transitions more carefully delineated as people move from setting to setting after their hospital stay. The stability of the bundle for both providers and conveners is directly related to the catchment area. As I said, the larger the catchment areas would lead more stable bundles with lower provider risk. In the next two charts, we're going to look at the toolkit that Teresa mentioned. We'll talk about the kinds of things that would go into perhaps a budget proposal or a formal BACPAC structure. The first is the trigger. The consideration is that, as I said, they initiated the day after discharge from the acute care hospital. The convener is incentivized to coordinate with the hospital to manage the transition to post-acute care as soon as clinically appropriate to reduce likelihood of adverse events. As you might imagine, as soon as a patient goes into a hospital, if there were a BACPAC payment system, there would be discussion started, where should this patient go? How soon would the discharge planners know that the patient should go to home health sniffer, and the discussion as to how to handle that patient, whether there was somebody at home to take care of the patient, would take place. And the trigger would be, that is to say, the bundle would start the day after the discharge from the acute care hospital. Clinical condition categories. Bundles should include diagnostic conditions that are both high in volume and represent a significant share of Medicare expenditures. We've been working with some BACPAC demonstration grantees, and they're looking at such things, again, as high volume, a high share of their expenditures, and they're also looking at bundles and clinical conditions where they seem to be high on the number of discharges and the dollars that they're spending on the bundle relative to their market area, on the grounds that if you're currently high, it might be easier to get lower to cut costs because your costs are high relative to benchmarks, which might be the regional cost for a particular clinical condition category. The bundle length could be 30 days, 60 days, 90 days. We modeled 60 days. Varying lengths are possible. We chose 60 days because it seemed to be a reasonable median between a short bundle of 30 days and a longer bundle of 90 days. Although a legislative proposal could have either 60 or 90-day or even a 30-day proposal. Or you might even have varying bundle lengths dependent upon the clinical condition. Some clinical conditions might require longer bundles, others might be shorter. Care settings included in the BACPAC proposal, the toolkit. The trigger is an episode following by a physician's order for home health, skilled nursing facility, or rehabilitation facility, inpatient rehabilitation facility. That's the trigger. That's the trigger, and a BACPAC bundle is included. What is included would be the emergency room, readmissions to the acute care hospital, both planned and unplanned, and outpatient therapy. We did not include physicians. Physicians would obviously be included in the care, and they would provide the order for the post-acute care, but they would not be included in the payment bundle under the current configuration of BACPAC. That's an open policy decision. It could be called in many ways, but our choice early on, and we modeled it without the physicians being in our bundle. The role of the convener is very complex and very important. A risk-bearing entity that manages the bundle and helps direct patient care transitions. The convener could be either a first PAC setting provider, presumably larger providers that have more financial capability and planning capability, or a third-party administrator. And the third-party administrator would take responsibility for risk and manage the bundle, would distribute payments to providers, the post-acute care providers, and the emergency rooms and the readmissions, and to some extent outpatient therapy. And finally, the role of the convener would be to select a first PAC setting, which would be the appropriate setting for a given patient on a given day, subject to all the things I've mentioned: ability to have care at home, clinically appropriate, and economically the most efficacious, most effective from the point of view of the convener. Page 8, risk adjustment bundles. With all the payment systems that Medicare currently has in place, there's some form of risk adjustment. DRGs have MSDRGs. Long-term care hospitals have LTAC MSDRGs. RUGs for SNFs, IRF-PI for the IRF settings, and home health has its own specific set of adjustments, as you well know. So you would have to have patient demographic characteristics, perhaps age and gender. You would have clinical characteristics, clinical severity. One thing that would be different with from all the systems to date, at least from the acute care side, would be functional ability. Each of the three functional status measurement systems for home health, SNF, and IRF measure functional ability, but they do it in a different way. And under BACPAC, there would have to be a common measurement system of functional ability, an assessment score across the settings. That would take place right at the discharge from the hospital, and then the convener would know the functional status, the functional ability, the clinical severity, and the comorbidities of the patient, and that would allow the convener to make an appropriate clinical decision as to where the patient should be sent, home health again, SNF, or IRF. We have talked about payment blends and transitions, and we modeled a 3-year historic average for the convener's history, the regional historic average, and our national historic average. So we have a 3-part blend. That blend could move very quickly or very slowly. MedPAC, in its report to Congress in March, wanted to move very quickly to reduce regional variation. We suggest caution in our report to say perhaps that shouldn't be rushed, and that until the systems are financially and clinically stable, more weight should be put on the convener's 3-year historical average payments. In effect, that risk adjusts the convener's own payments because you're taking advantage of the fact that risk adjustment probably wouldn't change too dramatically over time for a larger convener. Smaller conveners, you might get some stochastic movement in the risk adjustment, but the larger the convener, the more stable the population, and the more stable the population, the less the risk that the convener and the individual providers would take. The payment distribution can be done in 2 ways. One is called virtual payment. Virtual payment, in effect, means that CMS would pay each provider on fee-for-service, and if the dollars came up to higher than the allocated amount, it would have to be a take back from the convener. If there were, if the cost came in under what the CMS paid, there would be dollars to share, and the convener could take some of that for its administrative cost, and some of that would be split back with the post. The negotiated payments would work differently. CMS would have a total bundle payment, which would not be negotiated. That would be provided to the convener. The convener would then distribute the payments through a negotiated process to each provider. These rates, again, would be negotiated between the convener and the providers prior to the patient admission to the care setting. Under both arrangements, the convener was responsible for managing care and the transitions to ensure that total payments do not exceed the CMS-determined payment bundles. Very important fact here, and that fact is that under these kinds of bundled payment arrangements, what used to be revenue centers becomes a cost center. Under current fee-for-service and prospective payment systems, each unit is its own revenue center. Under a bundle, each unit within the bundle becomes the cost center and will be subject to scrutiny in terms of the amount of dollars expended on it. Hence the notion that the convener would try to reduce and minimize expenditures, again subject to quality measures and the appropriateness of patient placement within each setting upon leaving the acute care hospital. Now we'll turn to page 10, and we'll review analytic assumptions and findings. Again, just to reiterate what I said, the episode trigger would be the day after discharge from the acute care hospital. We decided to have the trigger right tight to the discharge so that the post-acute care providers and the conveners wouldn't be at risk for 2 or 3 days of downtime as the patient moved from the hospital to the first post-acute care setting. And so our trigger would be the day after discharge from the acute care hospital. The bundle length that we modeled was 60 days. Again, it could have been 30, it could have been 90, it could have been a lot of things. It could even be variable. We modeled a 60-day bundle, and that 60 days, again, starts the day after discharge from the post-acute care hospital. The care settings, the home health, the skilled nursing facilities, inpatient rehabilitation facilities could trigger the bundle. Planned and unplanned readmissions would be included. Emergency room visits would be included. Outpatient therapy visits would be included in the bundle. Again, we chose not to put physicians in because we figured it was a step too far, although you could argue if you don't have physicians in, you're going to have trouble managing the system. So that was widely debated over a period of time, and in the end we chose not to put them in on the risk side. That would be very difficult to manage up front in a newly formed system. We model conveners in 2 different ways. This isn't to say the way it would happen, but it's the way we modeled it. We modeled regional level convener catchment areas at the regional level, health referral regions where there were 306 conveners across the country. Again, that's a modeling assumption, not necessarily a policy assumption. And we also modeled hospital discharge level convener catchment areas where the catchment area was essentially the hospital area for each individual hospital. Again, that's not a policy decision, it was a modeling decision. The payment blend that we used was 80% convener, 10% region, and national was 10%. We believe that MedPAC would move a little more forcefully to national to smooth out regional variation. We would be much more slow and cautious in that and start with most of the dollars being set at the regional convener level. For instance, a 3-year payment average inflated forward would be what we would pay the convener 80%, then the broader region 10%, and the nation would be 10%. Now, at page 11, we give some indication. We built a fully specified payment model where on this chart we have payments to payments. Usually when you have a model like this, you go payments to cost. How much is somebody paid relative to their cost? In this, we meant how much would an individual provider be paid for a bundle, all the providers in a bundle, relative to current costs, how much would they be paid under the BACPAC model? So 40% means that an individual bundle would be paid 40% more than Medicare currently allocates under its fee-for-service system, and a minus, say we've got a minus 60 there, it's extreme. How about a minus 10, where there would be 10% less paid than currently is the case with fee-for-service. As you move from left to right, you're in bigger BACPAC Medicare expenditures, which would be larger catchment areas, larger conveners. And you can see that as you move from left to right, the dispersion around 0%, we modeled budget neutral, would tighten around plus or minus 10%. We wondered how this would compare after 30 years to the DRG system, and we built a table like this for DRGs, and it doesn't look a whole lot different, which is to say after 30 years in DRGs for each individual case, you still have a fairly wide dispersion at the case level of, say, plus or minus 20, 30% at the extreme for certain cases. So this kind of a finding is not inconsistent with the ability to build a system because DRGs have succeeded for 30 years, and they had results that weren't altogether different from this. But the one finding that I think is helpful is bigger is better in terms of financial stability, and that's what happens to the dispersion around 0 in terms of winners and losers, gains or losses, as you move into larger catchment areas. Page 12, we look at the smaller hospital areas, and it shows that there's a lot more winners and losers at the catchment area level as you have smaller catchment areas. And at very small catchment areas, you might have plus or minus plus 60 and minus 80, and it takes you have to move on out through the sides of the hospital catchment areas to get stability, and you have a whole lot of clustering of rather large pluses and minuses, larger than we have in the former chart, suggesting that larger catchment areas would be more financial actuarially. No surprise, really, but it's kind of interesting to actually model it and show for a system that hasn't been built through modeling how a larger catchment area would be more financially stable. In terms of implementation considerations, the first is, on page 13, quality measures must be implemented to ensure that providers are held accountable for outcomes and stinting of patient care is avoided. Very clearly, Medicare would not move forward with such a system without having a series of quality measures. One point to make is we have quality measures at the hospital level. You might argue how good they are, but at least we have them. But as of yet, we don't have quality measures for bundles. They would have to be built, they would have to be calibrated, they would have to be thought about, they would have to be put in place before we could have them, and that would probably be an ongoing process as we built and implemented a BACPAC kind of system. Freedom of choice must be assured for all beneficiaries. It's pretty clear that the Medicare program, since its inception, has had freedom of choice. Freedom of choice is waived in the Medicare Advantage programs, but the bundle program would not waive freedom of choice. That is to say, a beneficiary can come into a bundle, and the convener can recommend which facility a patient can go to, but in the end, the patient's freedom of choice reigns. And there's a lot of discussion of people that are working in the PIPSI initiatives as demonstration sites, how you coax or how you have a soft leveraging of patients to go to the network providers as opposed to going to the provider of choice. As it turns out in practice, most folks will go to the recommended site, but not all folks. And that balance is where freedom of choice comes to the play in the early implementation of the bundled payment systems and how it would certainly play out with a BACPAC type of bundling arrangement. We evaluated BACPAC. As I said, we took a look at winners and losers, and we have to note that payment compression, and by payment compression I mean that all of our case mix systems tend to overpay less severe patients and underpay the more sick patients. That's just a fact of life. We would have to be very careful that the so-called compression wasn't problematic and didn't lead to winners and losers, undue winners and losers that shouldn't be losers because the payment system wasn't working carefully. All of that comes back to you have to have a case mix system that you have confidence in, and you have to have a series of blends and transitions that don't force the system too fast as people adjust and understand how to live and work with the system. Determining the CBO savings, as I said, that if the Congress were to say BACPAC would save 1 or 2 or 3 or 4 or 5 percentage points, CBO might score it that way because that would be the law, just as in the states, when Medicaid undergoes managed care conversion, they often take 8 percentage points off the top, and in effect, that's how much they're going to spend to the managed care plans. And it's the managed care plan's responsibility to provide appropriate care subject to the budget constraint of -8%. In terms of further considerations, we have the inclusion of the LTAC admissions. We decided not to put the LTACs in because LTACs are outliers. Their patients seem to be different. LTAC patients seem to be measured in terms of medically instability, whereas the other post-acute care patients seem to be measured on dimensions of functional status. They're very different kinds of patients with very different, although I know there's crossovers, of course. Many LTAC patients can be treated in IRF and a SNF, and many SNF and IRF patients can be treated in LTAC. But at the ultimate, you have vent patients and LTACs in large part, and other kinds of patients that are less critically ill and less medically unstable that go to the SNFs and the IRFs. Exclusion of planned and unplanned readmissions. The frequency of observation stays in lieu of hospital admissions has increased. This whole business about what an admission is and what it isn't has been very complicated because the MACs are denying the hospitals many of their stays. They're calling them observation stays. All that said, we believe that readmissions probably should be a part of the package. Medicare is emphasizing very heavily the readmission process. There are penalties in place for certain MSDRGs in hospitals, and we've heard from our hospital clients that as these rules are being put in place for readmissions, the whole care process at hospitals and hospital discharge are being rethought considerably because folks are now saying if you have too many readmissions, there'll be a penalty, and that means the hospital has to think outside of its four walls. Indeed, that's what a bundle is all about, is thinking outside the four walls of a hospital and understanding better how patients are treated as they leave the hospital. The role of the convener and its interaction with beneficiary choices, I've noted, is critically important, very important in this process, and will have to be dealt with both by the government as it sets its rules. As you may recall in the ACO rules when they came out, the accountable care organizations, the biggest kickback on the initial reg had to do with beneficiary choice and over-prescribing of how beneficiaries were assigned to the ACOs. When we presented this to MedPAC, they raised two issues that are important. One of which was, when you pay on a bundle, might you get more bundles? So there might have to be some way of thinking about that you didn't get more admissions and more bundles. And the second one was a closely related issue was, what if somebody doesn't go to a post-acute care setting at BACPAC? How do you pay for that? And how do you handle the transfer between folks that don't go into post-acute care setting and those that do? So that concludes my formal remarks. We'll open up for comments now. And Teresa, it's back to you.
Thank you so much, Al, and I think that the presentation was really well done, and thanks everybody for your patience with some of the technical issues. We have gotten a couple of interesting questions from those of you on the phone, and certainly if you have a question and you have not yet submitted it, please use the in-meeting chat box on your computer screens to send me the questions. The first question comes from Jeannie Parker Martin, and the question for Al is, are there any conveners developing quality measures already that are being used in the BIPSI models that you've heard of?
We don't know that they've been formally put in place. We know that CMS will come up shortly with models, but in the folks we've dealt with, we haven't heard people explicitly say they'll have quality measures. What we have heard is people are developing assessment scales, and the assessment scales are designed in such a way that you have a much better sense of which facility a patient would be appropriate for. And in effect, it's working towards quality measures by making sure that patients go to the right place at the right time in the right setting, both clinically and economically. But we haven't heard of people formally putting in place. But I think the assessment scales, the so-called CARE tool, the B-CARE tool, and the burgeoning industry of assessment tools will be a first step towards understanding the clinical process better, which could then learn to the outcomes. And of course, we already have concerns with readmissions, and if you consider readmission a quality measure, that's built into the process. Fewer readmissions, in some instances, higher quality care, and that would be built right into the payment process.
Okay, great. Second question that came in is sort of related to a question I had. So this really has to do with sort of the applicability of the analysis that you've done, because the focus of the analysis really and the source of the analysis came from Medicare fee-for-service claims. And so I'm wondering if you can talk a little bit about whether the analysis is applicable only to Medicare fee-for-service only, And depending on your answer to that, what are the implications for Medicare Advantage and private payers? We got a question from somebody in the audience, basically about the fact that there are Medicare Advantage plans that pay on a per visit basis right now, which is typically lower actually than the home health agency's per visit cost. So, if bundling is really designed, the question really is, if bundling is designed to save money for the government and home health is sort of, the proven least costly alternative, able to deliver clinically appropriate and cost-effective care, how do we, how does it all fit together here given the climate with Medicare Advantage? So I know that's a lot for your question and for your thought.
Yeah, that's a very difficult question. I'll start at a high level. When we do what's called Congressional Budget Office scoring, and we take fee-for-service and we say, to throw out a number, $100 billion would be saved putting something into fee-for-service, the first thing that happens is the way Medicare Advantage is paid is based on the fee-for-service baseline. So if the Medicare baseline falls for fee-for-service, payments to Medicare Advantage fall. So that puts pressure. The fact that fee-for-service does something and does it well means there's fewer dollars going into fee-for-service Medicare, and that means the per capita allotment going back to Medicare Advantage falls as well. That's the first point. The second point is, a question that often comes up is, are Medicare Advantage plans already doing bundling, and are they doing it well? And as near as we can tell, they're not doing it often, and they're doing it very rarely well, which is to say that nobody really truly understands. By nobody, I mean very few providers truly understand the nexus between hospital care and post-acute care. And indeed, a carve-out system of something like a BACPAC bundle for Medicare Advantage, there's a major competitor building a system that would sell to the Medicare Advantage plans essentially a BACPAC system that would say, if you'll give us the carve-out for the post-acute care section of your Medicare Advantage plan, we'll take the responsibility, we'll take the capitated plan, and we'll make it work better. One question that I've asked over and over again is, in the private sector, in Medicare Advantage, what are those guys doing? And the answer is, well, they have some assessment scales. They're working real hard on reducing the number of readmissions. This is to say the MA plans. They're working on placement. But they don't have, very few MA plans have formal systems of bundling in place, and it's kind of an evolving industry. And again, it seems to be an opening for people external to the MA plans to come in and say, we will take over the post-acute care aspect of your MA capitated rate, and we'll take responsibility for that. You give us the capitation, and then we'll worry about how to manage your skilled nursing, home health, long-term care hospitals, and the like. So right now, I think it's a fairly fluid assessment of how one relates to the other. One thing for sure, if bundled payments are put in place, tools will be developed. They will then be used by the MA plans. It's not so clear right now that the MA plans are contributing a large amount to the toolkit for the bundled payment guys in the fee-for-service sector, although to some extent there have been some assessment tools built, and there has been some work with managing the length of stay of skilled nursing facilities and like in MA plans. But again, that's come externally from private sector vendors who are selling the product back into and inside the MA plans. Is that helpful? It's a very complicated question and a very complicated...
It is a complicated question, but I think that you answered the question well. So I've got a few more questions here, great questions again. One is from Barbara McCann, and it sort of relates to volume. So she's asking whether or not there might be, if you think about it on sort of an individual arrangement level, is there some minimum number of patients in any diagnostic category, and I think by that she might mean MSDRG, to begin efforts in bundling. So if you were to try to bring it down to the MSDRG level, like say you were to start with MSDRG 470, major joint replacement, could you think about, is there anything that you guys came across that might suggest what's the minimum number of patients to where it might make sense based on, the work that you've done and the analysis in BACPAC?
We've looked at that rather extensively. We don't have a definitive answer. When people build DRG type systems, to get the weights right, they like to have 30 to 50. 50 is better, sometimes 200. So somewhere between 30 and 200 seems like maybe a reasonable cutoff point. Since these are new systems, what people tend to be doing when we're working with clients external to BACPAC and we're saying, you know, how are you thinking your way through this? And they ask us, help us with it. We go to the ones that are the most frequent, never mind the absolute size, the relative most frequent MSDRGs. And given however large they are, however many people that is or the places they go, they are certainly staying away from the onesies and twosies and threesies and foursies. But let me just make a point on that. The way BACPAC will work is it will average across all the bundles. So you might lose on one bundle, you might gain on another. And DRGs, when we put them in place for the hospitals in the 80s, there were a lot of hospitals that only had one or two DRGs at the time. But, you know, it went into the mix, and they lose on some of those, and on the cats and dogs, so to speak. So we wouldn't want to get too hung up on the absolute size because you're smoothing across the MSDRGs. But to get started, it kind of makes sense. You go to your most frequent, your highest volume. Indeed, when Medicare put its 50 together, it went to the 48 families. And the 48 families represented, Audrey, 80% of the cases and 80% of some number of the MSDRGs. And people are really thinking about consolidated condensing to get started with. But in the longer run, you kind of smooth across the MSDRGs, and the fact that you only have a few of this and a few of that probably isn't too important. But that's the longer run. In the shorter run, you want to get your systems in place, you want to understand your care coordination, you want to get your tools built. As somebody suggested, you want to build your quality measures or work with the government to build those. Most likely we're going to do that where we have the most cases, the most confidence that what we're doing makes sense, and we'll have fewer failure rates. So my guess is you go to the ones that are the most dollars, the highest frequencies. The top 20% of MSDRGs are 80% of the dollars, and that's probably where we'll end up, is something like the top 170 DRGs are 80% of the dollars, and within those, the top 30 or 40 are a large number of cases. And my guess is we'll go with a 5 or 6. You know, you can guess chronic disease, chronic heart failure, diabetes, congestive heart failure, COPD, joint replacement. We're going to go to the big ones when we get started and then spread out is my guess. And that's certainly what the people we're talking to are thinking about.
That's also the importance of the catchment area for the convener, is that since you want to have enough volume to mitigate your risk as much as possible, the larger the convener, the more volume that they would be dealing with. So this just all comes back to, I think we have in our final report that we find stability somewhere around 200 episodes. But the larger the convener, the easier it is to reach that volume, so the more they're able to mitigate their risk.
And Audrey reminds me of a very important point. I had forgotten, we formally modeled that, and we came up with a statistical answer of about 200. The MedPAC report also has an estimate, I believe it's also 200. So MedPAC and Dobson DeVonzo came up with essentially the same number. I gave you the longer answer because in practice, the 200 isn't nearly so important as for you as an individual provider, where's your action? But as a statistical matter, Audrey's just exactly right. We at Dobson DeVonzo and MedPAC found about 200 is when you get statistical stability.
That's great. We've got one more question, and I think that this has to do with trying to connect this analysis with what's going on in reality and practice all over the country. And, you know, the question really is, you know, is this work that you've done, is this a purely hypothetical model, or do you know of similar models that are being used today that, you know, that your toolkit might be analogized to? And go ahead.
I think that we have, if you go back, I don't know how many years Geisinger's been working on it, but Geisinger has what they call care reengineering. Care reengineering may be a first version of bundling. The so-called the ACOs, the care organizations, are a form of this. They have bundling within them. And I think many, Mayo, the Cleveland clinics, folks have had bundled payment arrangements for certain diagnostic conditions. I think there are predecessors, but nothing of the extent and range of this. And one thing that we discovered in the past 2 years is, if you go to, say, an individual hospital, and you ask the hospitals, how many skilled nursing facilities, how many home health agencies do you deal with, they really don't know. In fact, we were presenting data to a client the other day, and Audrey, we had how many SNFs?
201.
201 SNFs for 3 hospitals in a moderately large MSA area, which if you think about it is kind of stunning. But therein lies a very important tale, because if they're dealing with 201 SNFs, they want to get it down to 5, say. I just made the 5 up. But we've been hearing that folks want to drive their panel down to a smaller number, certainly not 200. There's going to be a lot of movement in the marketplace around who's in the panels, who isn't in the panel, who relates to whom, and as the shakeout comes, I would expect there'll be a lot of discussion about who's on the panels and who isn't in terms of how this thing is going to evolve through time. But in answer, are there any operational ones? Not really, although the BIPSIs are starting to formulate. We're providing information to people, and others across the country are, as they're really getting down to the hard questions. How are we going to make this thing work? Which MSDRGs are we going to use? Who's going to be our partners, and how are we going to contract with them? I think all of those things are under discussion as we speak.
That's great. We're at the top of the hour. I want to thank you, Al and Audrey, for your terrific presentation, and I want to thank everybody for their patience with the technical issues. All of the materials for the BACPAC analysis are on the Alliance's website. You should see on screen the link to those materials. You'll find there the full report, the presentation slides, the press release, a 2-pager, and keep an eye on this website, because we might be providing some additional background information as well that might be helpful as everybody is thinking through these issues. To be sure, I think that one thing that we can come away from this is that change is absolutely afoot. It serves us all to really understand some of the technical issues that underlie bundling arrangements and where the risks, pitfalls, and choices lie. So again, I want to thank everybody, and if you have any questions, please do reach out to me, Teresa Lee at the Alliance, or you can reach out to our researchers at Dobson DaVanzo directly. So with that, I want to thank everybody and have a wonderful day.